To the Clarity Mandate with me, Dr. Vivian Atud. Today we're doing a live on one of the really most important topics of the day. And today I am looking at AI governance in healthcare. AI governance in healthcare. And the question is, what happens when a computer decides that you are low risk? But guess what? You know deep inside you that something is really wrong. I was talking to a friend recently, and what happened to this friend? He's been having this pain consistently for a while, and he went to the hospital and was told he's all right. You need to go back home because the systems, the algorithms, and all that. And deep inside his mind, he knew something was wrong, and he insisted and said, "I want further tests, I want further scans, I want further this, because what you are telling me does not coincide with what I am facing." And guess what happened? After doing detailed test and analysis, it was actually revealed by the result that this friend was actually diagnosed with stage 4 renal cancer. The models, the predictions said everything looked okay. Get some painkillers, get this and go. And inside of his mind, he said something was wrong. And the question today, when we look at AI and models and diagnosis, is what happens when your physician, your doctor sees some physical symptoms, but sitting beside those symptoms is an algorithm or a score that, in clinical terms, is telling your doctor that the patient is unlikely to deteriorate. The patient is okay. The question is, who wins? The patient, the physician, or the predicting algorithms? And for me, here is the deeper question when it comes to AI governance in healthcare. The question is, what if the predicting algorithm was trained on a particular healthcare system that did not treat people equally? We all know that we are living in a world, it doesn't matter what region of the world that you are, we are living in a world where we have racial biases. When you look at healthcare data, there are lots of inequalities when you look at this. And now in the AI era, AI is even going to amplify these differences. If you're joining us live on the Clarity Mandate, we are looking at AI governance in healthcare. And you are welcome again to the Clarity Mandate. This is Dr. Vivian Atud. And today, like I said, we are confronting one of the most important questions for the future of healthcare. This is our future, the future of our children, the future of our grandchildren. What is going to happen in healthcare as far as we are navigating this AI era? And when you look at how artificial intelligence is becoming increasingly embedded in healthcare and clinical decisions, how do we protect patients' agency from predictive biases? Because we are already seeing these biases in all sectors. Because guess what? The greatest danger may not be what an algorithm, maybe an algorithm that is broken. Yeah, the algorithm may work very well. Technically speaking, it has no issues, it can predict. But guess what? The danger can actually be an algorithm working with a mathematical model that maybe is so sophisticated, and guess what? It is efficient, everybody can see the efficiency, but guess what? It is optimizing the wrong thing. It is optimizing the wrong thing. We are talking about AI governance in healthcare, dealing with algorithms that are doing very well as far as the predictive capacity. They can predict, they can do this, but guess what? These algorithms are optimizing the wrong thing. And I want us to look at how I want to really start with something for me that will help us to fundamentally understand AI governance in healthcare, because algorithms do not have to contain explicit prejudice to produce unequal outcome. I want to emphasize this. They don't have to have explicit prejudice. They might look like, oh, this is just because if you look at some research, one of the most important demonstrations of this came from a study that was done in 2019. Guess what? The researchers examined a widely used healthcare risk management algorithm, and this algorithm was designed to identify patients who should receive additional care management support. This is in healthcare. They say this algorithm is working very well. Can you identify for us patients who should receive additional care management support? And guess what? The algorithm did not simply contain a rule that said discriminate against Black patients. No, it did not have that kind of a rule. Nothing obviously happened when you look at that algorithm. The problem was more subtle. The problem with this algorithm was more hidden. The algorithm used what? Future healthcare spending as a proxy for healthcare need. Future healthcare spending as a proxy for healthcare need. And that sounds logical, yeah? People who will spend more might actually be the people who will need more. But guess what? Sicker patients cost more, that's true. And therefore, if we predict the cost, and perhaps you can identify the people who need healthcare more. And except that there was a fundamental flaw. Because guess what? Because of inequalities, um resource inequalities, Black and white people and people of different races don't have equal access to resources, so people will spend less even though they are sicker because they can't afford. So what happened was that Black patients, if you want to compare their sickness levels historically, they spend less. Why? Because they cannot afford, not because they are healthier. So the algorithm, on the one hand, could predict that healthcare costs reasonably could actually mean that this particular population needs more healthcare. But guess what? This algorithm could be wrong because there are people who need healthcare, but simply they can't spend more. So for me, when you look at the risk score, you will see that Black patients are more sicker than white patients in many cases. But guess what? Researchers actually did some correction of this algorithm. And guess what? What did they see? They saw that if you actually focus on looking at the different races in terms of building these algorithms, what happened? You were going to be able to increase the the number of Black patients who needed care from 17% that were predicted by the algorithm to about 46%, 46.5 actually. I mean, think about what that really means. Something that predicts that only 17% of Black people are going to need more health care, but when they try to correct for actually how many Black people were sicker, they actually found that it was up to 46, more than double, 46.5. So the algorithms in this AI era can succeed mathematically, but guess what? They can fail morally because the target itself was wrong. The target, and for me, that brings me to what I call the wrong target problem. So if you ask your AI to optimize the wrong objective, what is going to happen? It will do it very accurately, but guess what? It will not save you, especially when we're talking about healthcare, where you are dealing with human beings. patients that needs help. So greater accuracy when it comes to the AI era may simply allow you to go ahead and optimize the wrong objective more efficiently. You're going to be right in optimizing your objective, but guess what? You would not be right in actually predicting what you set out, the problem you wanted to solve. And for me, when you looking at the incentive, looking at the data, for me, this is where economics becomes what? Essential in AI governance. The importance of economics in AI governance, especially in healthcare, because healthcare systems face real constraints. Talk about limited clinical time, talk about limited staff, talk about limited beds, talk about limited budget, talk about growing patient populations. I mean, if you spend a day in emergency or in any healthcare work, you would come to appreciate this. Talk about administrative pressures. Talk about reimbursement structures that are becoming complex and complex by the day. Talk about utilization management, cost containment. I mean, these are real economic pressures. Efficiency is therefore not an evil thing, because you want to become more efficient in dealing with these real constraints. You want to deal with it, but we need, what do we need? An efficient healthcare system. But for me, here is the governance question. When we are talking about efficiency in healthcare and talking about efficiency and using AI to optimize real economic problems that you find in healthcare, you need to look at the governance question. And for me, the AI governance question is efficient at doing what? Suppose an organization says, oh, we want to identify the patients who most need intervention. That is a stated what? Clinical objective. But the variable, the model actually predicts what? The model predicts who will cost the most. Remember, they want to look at who needs intervention, and the model is looking at cost. Those are not automatically the same objective. Those are not automatically the same questions when you look at it technically. So that is where you have hidden cost when you look at AI optimization. The decision about what the model should predict is not purely a mathematical one. It is a governance decision. I cannot overemphasize this. The decision about which data should represent need is not a technical decision. It is a value decision, especially when it comes to healthcare. And that is where the threshold that determines who receive additional intervention is not merely mathematical. Like I said, it's an allocation decision. And allocation is what? Economics. Allocation is economics. And for me, this is where the question of responsible AI governance, you cannot leave it exclusively to data scientists. We need clinicians, we need ethical people, we need economists, we need compliance professionals, we need patient representatives, we need executives, and we need all these people. And critically, we need someone in the room whose job is to ask, what happens to the human being when the model is wrong? What happens in healthcare systems? We're talking about AI governance in healthcare systems. What happens to the human being when the AI tells us wrong thing? And for me, now people often say, the problem with AI is that it's a black box. Sometimes that's true. AI is like a black box. Yeah. But guess what? Being a black box is not only the problem that you don't see how the model works in the background. That's not a problem. And there can be a perfectly, because many people are talking, oh, we can explain. Explainable AI can still be unfair. Explainable AI can still be telling you the wrong thing. A transparent algorithm can still optimize a terrible objective. It's always about what are we optimizing for? What are we actually doing? Because guess what? A model can be clinically accurate in a hospital, and guess what? It can underperform in another hospital setting. A model can perform well when it is deployed. A model can deteriorate over time. And that is why the FDA has specifically highlighted this problem. And the FDA talks about changes in patient demographics, clinical practice. It talks about data input, what kind of data you actually put into the system. It talks about healthcare infrastructure. It talks about workflows. Look at the workflows that can produce when the data can drift from one area of focus. And guess what? This can actually over time affect the performance. And guess what? It can also lead to what? Biases. And that's where the FDA is saying that it is important that in the real world, when you are using AI in predicting healthcare outcomes and healthcare on healthcare data, you need to keep evaluating it. You don't have to treat pre-deployment testing as the end of governance. Over time, you have to keep evaluating. And for me, that is very, very important, because healthcare AI governance cannot simply be, oh, we tested the model, we approved the model, we deploy the model, and everything is okay. No, healthcare AI governance has to be, we tested the model, we validated the model, we continue to deploy it, we monitor it, we compare it, we change, we correct, and we keep doing this over and over and over, because you are dealing with human beings. You are dealing with human beings. And guess what? What happens when the model leaves the lab? And I want to give you this example. Researchers independently evaluated the widely deployed EPIC sepsis model at Michigan Medicine. And guess what? They tried to study over 27,000 patients across over 38,000 hospitalizations. And guess what? The models, if you look at scientifically, what they saw is that the model underperformed. It underperformed than what the developers had actually predicted. And the researchers concluded that the model performed what? Poorly in predicting sepsis in that particular setting. And now, this does not mean that the predictive model cannot improve what? Sepsis care. It means that sometimes something more important might be underlining. It might be performance can be contextual, because this model did well in different contexts. When it was taken to the Michigan hospital settings, it did not do well, which means it could do well in another setting, but not do well. A model can not be, you can't just say, use the word accurate loosely and say this model is accurate. No, you need to ask, accurate where? Accurate for whom? Accurate using what data? Accurate at what threshold? Accurate under what workflow? Under what circumstances? And guess what? Compared with what alternative? Because some other models might be more accurate than that model. So you need to look at all these. So, and after what period of deployment? Because a model can be accurate for a particular time. And that is why external validation of any model that you want to use in a healthcare system in this era of AI becomes very, very important. That is why local validation, external validation of models used in AI systems becomes very, very important. It matters. And if you're a CEO and you are bored, you cannot just accept what the vendor says. Oh, our algorithm is 91%, 92%, whatever percentage accurate. And you need to consider the governance question and ask 92%, 94% of what? Sensitivity, specificity, positive predictive value across what population? Because you are dealing with human beings. And what happens inside the missing 8%? If they say, oh, it's like the COVID vaccines. Oh, they say it's this percent successful. You need to look at what happens at the remainder. And because in healthcare, average Anything you talk about average, you're dealing with human beings. You're dealing with human beings. And guess what? That's why the World Health Organization places the protection of human autonomy first amongst the 6 principles of AI governance that it talks about in healthcare. If you look at the WHO, it argues that humans should remain in control of healthcare systems, medical decisions, identifying transparency, accountability, safety, inclusiveness, and equality at central what governance principles when it comes to AI in healthcare. And guess what? This matters. This is very, very important. And thank you, everyone that is joining us live across platforms. Keep putting some fires in the chat. We're talking about AI governance in healthcare. And we're looking at what the WHO is talking about, the role of humans in healthcare. Because unlike in other matters, think about it. If Netflix recommended to you a wrong movie, you lose 2 hours, for example. If Amazon recommended to you the wrong pair of shoes, you can return them, or maybe you lose $50. But when a predictive model influences whether your symptoms can trigger escalation, whether your scan is prioritized in a healthcare system, because guess what? These systems they are helping people to be cured in hospital. Whether this one needs escalation, this one needs urgency, this one can be put at this level, and whether your risk is classified as high or low risk. And these are AIs talking about your health. Whether additional monitoring is recommended for your health situation. You might be critical in a hospital, or whether a physician's attention is directed somewhere else instead of you. The consequences can be greater. It might be loss of life. It might be making some situations worse. So when it comes to healthcare, mistakes of AI can really be very consequential, and therefore patient agency cannot become a collateral damage in the pursuit of what? Efficiency. And for me, here is a question that I believe healthcare executives should wrestle with. If you're a healthcare executive watching or listening to this episode of the Clarity Mandate, you need to begin to think about this question. If an algorithm materially influences a consequential decision about a patient, what does the patient have a right to know, challenge, or appeal? If an algorithm materially influences a consequential decision about a patient's health, what does the patient have a right to know, to challenge, to appeal? Because guess what? These algorithms are already predicting things about patients. And what if they are wrong? What are the rights of the patient? I'm not suggesting that every mathematical calculation needs a 20-page consent document that will make healthcare very impossible. What I'm arguing is that something more fundamental needs to happen, and the greater the potential consequence of an algorithm, the recommendations that AI are making, the stronger the governance around the transparency. Human reviews, recourse should become something that it's very seriously taken across healthcare systems. For me, there is the talk about human in the loop, and I am saying this is great, but this is not good enough. This is not good enough. And I'm going to make the case for human in the loop alone. It's good. It is not good enough. And because this is another area where organizations can create what I call false comfort. And they say, oh, don't worry. There is always a human in the loop as far as this AI system is concerned. But if you put a human somewhere in a workflow, if you've done analysis of workflows, that does not automatically create meaningful human oversight. Guess what? If the clinician cannot understand the model's intended use, it cannot see the limitations, the clinician does not know which population it was validated on, and cannot even meaningfully override the recommendations that the AI is doing. You cannot meaningfully overwrite it, or even is under intense workflows, because if you are working in a hospital system, healthcare systems, there are always overload and overflow. Guess what? You can accept some output, then the human may be technically in the loop, but guess what? Functionally exercising very, very little oversight. And that's why the FDA, if you look at the transparency principles of the FDA, it predicts that the human AI team that is providing users with the necessary and essential information, communicating known biases. If there are any known biases, let the people know. If there are any failures, let the people know. You need to train, you need to test the data, and you need to do what? Support local validation and ongoing what? Performance monitoring. Ongoing performance monitoring. And if you look at the American Medical Association, if you look at their current ethical guidance, it's also similarly like the FDA one, emphasizes that AI should not replace physicians' oversight or autonomously make life and death decisions without what? Appropriate governance and accountability. So here's my argument. Human oversight must be competent oversight. It cannot just be something, oh, we have a human in the loop. The doctor needs accountability. The organization needs accountability. And guess what? The patient needs protection. The patient needs protection. And for me, I don't leave any discussion, any episode without making a suggestion, and that's what I call the patient governance framework. And so the question is, what should a healthcare leader do? And for me, I introduced this patient AI governance framework. If AI is affecting patients, governance has to begin with this very patient. And I'm going to look at all the letters of the word patient as I introduce this framework. P stands for purpose and proxy integrity. So before asking how accurate this algorithm is, you want to ask, what exactly are we asking it to optimize? Are we predicting disease? Are we predicting mortality? Are we predicting utilization? Are we predicting cost? Are we looking at readmissions? Are we looking at clinical deteriorations? Are we looking at eligibility? Are we looking at resource use? And if we are using a proxy, ask why. Why are we using a proxy? Because guess what? Could historical inequalities contaminate this proxy? And for me, that is the first clinical governance audit question that you need if you want your AI models in healthcare to work well. And A talks about accountability. Every consequential AI systems need a named accountable owner, not the AI department, not the vendor, not the IT, a person or governance body who has what? Authority to suspend the system, who investigates adverse outcomes, who reports to the board, who approves measure model changes as far as AI, who carries responsibility when clinicians repeatedly identify problems with this AI model. And if everybody owns AI governance, guess what? No one owns AI governance. So it has to be a named person or a named institution. And T talks about what? Transparency and traceability. Organizations need to know who built the system, What is the intended use of the system? What data informed its development? What populations were represented? What are the known limitations of this particular AI system that we are using? What model version is currently operating within our organization? When was it last updated? You need to know all this. What decisions did it influence in the past? Because it's going to help you as far as your governance of AI. Can we reconstruct what happened? Can we reconstruct it? So the FDA, if you look at the FDA transparency principle specifically, it talks about intended use, it talks about target population, it talks about training, it talks about retraining, it talks about testing the data, it talks about known biases, it talks about limitations. It talks about confidential information where appropriate, and it talks about what? Monitoring changes. And transparency for me is not just publishing proprietary source code. Oh, we've published a code. Transparency really means, as far as healthcare AI governance, that you are ensuring that people that are accountable for clinical consequences have what? Enough information to exercise meaningful judgment. That is transparency. They need to have enough information to exercise meaningful judgment. And the I in patient stands for what? Inclusive validation. Do not stop at overall accuracy. Oh, the model is accurate. Yes, accurate, great, thumbs up. But guess what? You want to disaggregate performance where appropriate and legally permitted. You want to examine, look at things like race, look at things like sex, look at things like age, look at things like disability, look at things like language, and look at things like relevant socio-economic conditions, geographic populations, clinical subgroups, rare disease groups, and you want to add other factors that are relevant to the specific use case, and you want to ask, does sensitivity collapse for one population? Is it that when we move from one population to another, do we still have consistent outcome? Does the false negative rate rise in a particular population? Does calibration change anything? Was one group underrepresented in the development data? So once you begin to look at all of this, you begin to see, and that's why the WHO specifically cautions that AI trained mainly on data from high income countries may not transfer what? Reliable information to low income settings. I mean, if you look at AI models, maybe trained in the US, you take it to some parts of Africa and other parts of the world, they might not deliver the same results because the populations are different. And this has what? Profound implications for Africa and the global south. So you should not, and you cannot simply export an algorithm that is trained somewhere else and assume biological, clinical, infrastructural, and socioeconomic equivalence. You need to do what? Localize your AI. AI governance needs to be localized. And E, as far as patient is concerned, we're talking about escalation, we're talking about explanation, and we're talking about override. So what happens when a doctor and an algorithm disagree? A doctor, which is a physician, and an algorithm disagree. Who wins? And for me, my answer to this is there should not be a defined, or there must be what? A defined escalation pathway, not blind obedience in any either direction. You don't just have to conclude that, oh, in this case, the doctor wins, or in this case, the AI wins. There has to be systems to escalate so that you really look at fundamentally what caused this disagreement. The physician should be able to challenge the model. Yes, they should be able to produce documentation that can be used to overwrite the model. And If there is repeated disagreement between what the model is predicting and what the doctors or the humans are saying, then what happens? You need to investigate the AI model. It needs to trigger investigation. And high consequence cases should receive what? Proportionately stronger human review. You need to bring more humans in the loop, proportionally human reviews. And guess what? When doctors see when their models are telling them things that don't protect patients, they also have to do what? We need to take these matters up, escalate these matters so that we are able to deal with the differences. And as far as the name patient is concerned, is you want to notice the patient agency and the recourse. And for me, this dimension, I believe that it requires more attention. For consequential use, think about a patient doesn't have to become passive. You're using your data to deal with what you predict, what the AI needs to do. You need to be able to look at how the AI organization determines, or the healthcare organization determines, when should the patient be informed that AI materially influenced their care. When is it meaningful? When do you need meaningful consent from the patient? When is that appropriate? That we're going to be doing some things on you, but we're going to rely on some information that is coming from AI. Can the patient request human consideration? If an AI says this concerning my health, I would like to have a second opinion. I would like to have a human opinion. What happens if an algorithms or the decisions that your AI make about a patient is inconsistent with the clinical reality of that particular patient? What is the appeal mechanisms? All these things have to be clear. And that is why the WHO explicitly connects. You look at responsible healthcare AI with autonomy. Autonomy, meaningful human control and mechanisms through which people can question decisions and seek redress when algorithmic or algorithm decisions adversely affect their health. For me, that has to become something that across healthcare systems, we need to look at how do we ensure that we protect patients in this AI era. And T, I'm talking about tracking after deployment. Whenever you deploy an AI system in the healthcare department, you want to track it, track the system. Don't govern yesterday's model while today's model is behaving differently. No, you need to monitor clinical outcomes. What are the outcomes? You need to look at what are the false positive, what are the false negatives, and then where do I overwrite? Where do I overwrite? You need to look at once you override things like this, you need to look at how does this thing work in subgroups, in patient, how does the model fit? So when you look at how does it operate in changing populations, changing in clinical guidelines, maybe you need changes in your data architecture. And that is why the FDA has explicitly identified real-world monitoring and drift detection as important issue when it comes to AI-enabled medical devices. AI-enabled medical devices. AI governance is a life cycle discipline. You need to do it over and over and over and over. And for me, this is no longer a simply academic decision or discussion when it comes to healthcare governance, because guess what? You look at the US, there are several regulations. I mean, many people are going to be in trouble if they don't follow the law. There will be lots of court cases coming because there are rules that are already talking about transparency for AI and other predictive algorithms that you are using in healthcare systems. So you need to be able to do what? Comply. You need to do the right thing. Whether you're looking at the FDA regulations, you're looking at different regulations, the direction is clear. we bought the algorithms. You cannot say, oh, we bought the algorithms from the vendor. This cannot be an adequate governance strategy. Healthcare organizations need institutional capacity to understand and to govern the technology that they are actually kind of deploying to use on humans. So for me, let me challenge the other side of this conversation. We've been talking about AI and batching AI, but guess what? AI is not the devil as far as healthcare is concerned, because guess what? Even human beings have their own biases. AI might actually be helping us to deal with some human biases despite the limitations of AI. So clinicians over time have misdiagnosed. It's not a new thing. We have medical malpractices all the time, and these cases come all the time. Healthcare systems already contain what? Disappropriate inequalities. We see this across jurisdictions, across countries. And guess what? AI actually has the potential to improve lots of this. And the WHO has actually recognized the potential of AI to improve diagnosis, to improve the speed, to improve the accuracy, to strengthen even the clinical care and expand access to healthcare, including even in resource-constrained environments. So AI can potentially identify patterns that humans miss. It can support overload clinicians. It can actually enable earlier interventions when it comes to healthcare and save life. AI can actually help to democratize specialty interventions. So here is a question. It's not about humans or AI. That is a simplistic question. The question is, what architecture of human and machine decision making produces the safest, the fairest, and the most accountable healthcare? So you want to bring both humans and machines, but you want to produce a fair, you want to produce a safe and a fair and a what? A fair and accountable healthcare system. So if you are a CEO of a hospital, or you're an executive, or you're a leader, you're an insurance executive, you're a technology company, you're a regulator, and you are watching or listening to the Clarity Mandates talking about AI governance in healthcare, you're a board member, I want you to take these 7 questions to your next governance meeting. I want you to take these questions. I want you to take note of this question. And question number 1, what consequential AI systems are currently influencing patient care in our organization? What are the systems? Question number 2, what objective is each model actually optimizing for? Question number 3, what populations are represented in its development and its validation? Question number 4, do we know performance by clinically relevant subgroups, not simply overall accuracy? Question number 5, who has authority to override, to suspend, or to retire a model? And question number 6, what happens when a patient or clinician challenges the decision that is being made by an AI? And lastly, how will we know if the model becomes less safe in 6 months after deployment? If your organization cannot answer those 7 questions, you do not have an AI governance system in your healthcare. You have AI deployment, yes, you have AI. And those are not the same thing. You can deploy AI, but you don't govern the AI. And for me, the future of medicine will almost certainly contain more artificial intelligence. There's no question about that. But that is not necessarily something to fear. That is not something to fear. But there is something that we need to protect intentionally. The patient cannot become an inconvenient variable inside an efficiency model. The physician cannot become merely a human signature beneath an automated recommendation. An executive cannot outsource what? Ethical accountability to software vendors, because guess what? These algorithms, they don't determine their own values. We do. Algorithms do not decide what counts as success. We do. These algorithms do not decide whether cost is an adequate proxy for need. We do. Algorithms do not decide whether a false negative is accepted. We do. And ultimately, algorithms do not carry moral responsibility for healthcare systems that we build. So human beings do. So perhaps the most important question in healthcare governance and healthcare AI governance, it's really going to be how intelligent it's not going to be how intelligent are these machines going to be. It's going to be how accountable will the humans remain. And for me, this has been Dr. Vivian Atud. This is the Clarity Mandate. I will see you in the next episode.